Okay, for the second paper, I will call Dr. Dileep Kumar and Dr. Rabbiya Ali from Karachi. Dr. Dileep Kumar is an FCPS MRCS consultant general and laparoscopic surgeon. He is working currently as a research associate in CDPWA. He worked as an associate professor at Ziauddin University Hospital and JMDC. He has published multiple research articles and case reports in national and international journals. Dr. Rabbiya Ali is an FCPS MRCS surgeon who is consultant at Department of General Surgery Unit 6 at Dow University of Health Sciences, Karachi. Please, both of you can come on the stage. Okay, from over there.
Yes.
Okay.
Hello everyone, my name is Dr. Dileep Kumar. Today I am going to present my topic on the role of neoadjuvant chemoradiotherapy on the signet ring cell adenocarcinoma. And
Can you please show the slides?
I am really sorry that I could not face the audience and the screen at the same time because of my disability. I am presenting from here.
Yes, please show the slides. Yes, I gave.
Slides.
Start.
So the topic is to assess the role of neoadjuvant chemoradiotherapy on signet ring adenocarcinoma of rectum. Next. Next. So briefly, I am introducing what are the signet ring cells. Basically, these are the cells which have intracytoplasmic mucin, and these are the group of some neoplasms which have very high aggressive behavior, and they do not respond to chemotherapy overall. And if there is a presence of intracytoplasmic mucin, we label it as a signet ring cell. And if there is an extracellular extracellular mucin, we label it as a mucin. And those cells which have both the components, we label it as a mixed mucinous and signet ring cells. The literature, previous slide. The literature is somehow the signet ring cells is more prevalent in the Indian subcontinent region with overall 13% prevalence rate as compared to 1% in the Western population. And in Western population, the left-sided signet ring cells are more common as compared to the Indian subcontinent Pakistani region, where the left and right-sided both the signet ring cells are present. Because of the younger age at presentation and the greater propensity of the peritoneal metastasis and frequency of nodal involvement, and it carry a very worse prognosis. Next. So what is the appropriate approved strategy to encounter these cells? Normally what we do is we definitely do the neoadjuvant chemotherapy to shrink the tumor size in the rectum, so that we get the cuff of at least 2 to 3 centimeter of tissue, so that a low anterior resection or sphincter saving surgery is performed. So the strategy is initially, if the tumor is obstructing, we used to do the divergent stoma and then do the neoadjuvant chemotherapy to shrink the tumor size to perform the sphincter saving surgery or definitive surgery. And after that, if feasible, then adjuvant therapy and the reversal of the stoma. Next. So most of the literature evaluating the effectiveness of neoadjuvant therapy assess all the local advanced rectal carcinomas altogether. However, the signet ring cells behave differently from the conveniently encountered adenocarcinomas. Hence, these results cannot be generalized. And our study is retrospective view, and we want to investigate whether there is any role of neoadjuvant therapy only for the signet ring cell or mucinous carcinomas. So ethical review board has been taken into confidence. Next. So overall 220 patients were admitted in colorectal ward, and out of which 182 were having the general conventional adenocarcinomas, and 38 patients were belonging to mucinous or signet ring cell carcinomas. out of which 2 patients were metastatic and that were excluded, and the 15 patients who are mostly on the right sided are rectosigmoid tumor, and that has been excluded. So only 21 patients are fit to be included in our study. The staging is done by the natural convenient methods like CT scan, MRI of the pelvis, and colonoscopy, biopsy, and all these tumors were presented in the multidisciplinary meeting, in tumor board meeting before referred to the oncologist. Next. So the primary outcome of this study was the T-stage assessment, how much the tumor has been shrunken from the T3 to T2 or T4 to T3 stage. So after the neoadjuvant chemotherapy, the patients were re-evaluated, restaged by the CT scan or MRI pelvis. So the record has been inserted into the SPSS version 22, and then the results were obtained using the various tests. Next. So the mean age in our study was 37 years, that is very quite young years as compared to the international research data that shows the mean age is 57 to 60 years. 13 patients were the male and 88% were the female, and in histological subtype 16 patients belonging to signet ring cell and 2 patients belonging to mucinous and 3 patients having both the components of signet ring and mucinous. Regarding the cellular differentiation, 20 patients were poorly differentiated and all these patients were signet ring cells. Only the 1 patient who was moderately differentiated, that was the mucinous carcinoma. And and there is a partial, there's only the 14 patients were the partially obstructed, and while the 6 patients were completely obstructed. The involvement of the mesorectal fascia were in the 17 patients. So before neoadjuvant therapy, the 5 patients were belonging to the T3 group, and out of these 5 patients, the 4 patients progressed to the T4 after neoadjuvant therapy, while the 1 patient remained in the T3 stage. And in T4, 16 patients were in the T4 group, and after neoadjuvant 20 patients that were progressed from T3 to T4, and none of the T4 patients were regressed to, and there's no change in it. The p-value is 0.238, that is quite high, and that shows there's no difference in the neoadjuvant chemotherapy. So this is the graphical presentation. Next. So the discussion will be done by given by the Dr. Rabbiya.
Thank you, Dr. Dileep. So the discussion of our study is that the clinical experience is directed to evaluate the efficacy of neoadjuvant therapy in the treatment of SCRCs. And as evident from the study, neoadjuvant therapy is a standard of care, but it failed to produce satisfactory results in our study. So the finding of the study is to depict the treatment resistance and violent nature of the signet ring cell tumors, those reported elsewhere. Neoadjuvant treatment considerably improved outcome in trials involving locally advanced rectal cancers. However, it was not apparent from our study. This difference can be attributed to the fact that our study only included signet ring cell tumors, and it has not received sufficient representation in other trials yet. So we left metastatic tumors. A point to be noted is that the mean age of the patient in our study is 37 years. But so far, the least age group I saw in study is the 13-year-old guy in our study. While the prevalence of signet ring cell tumors in cohort was higher, that is 13.7%, than the 1% reported in the literature, It is nevertheless equivalent to that of the developing world, notably to the Indian subcontinent. So neoadjuvant therapy is a component of the standard practice used for locally advanced tumors, and it has shown promising results in the treatment of adenocarcinoma of the rectum by downstaging the tumor, followed by surgical exploration. However, these benefits are largely observed with common conventional adenocarcinomas. So the signet ring cell needs more attention exclusively because it is a rare tumor. One trial comparing the choice of neoadjuvant therapy illustrated that no matter what type of neoadjuvant strategy was employed, the prognosis of signet ring cell tumor remained poor, as shown by dismal disease-free survival of 18 months and half of the patients dying of the illness in 3 years. None of the patients from our cohort benefited from the neoadjuvant therapy. Instead, due to the time consumed during its administration, the tumor advanced to a higher grade following its natural course. This is demonstrated by the fact that the 4 patients in the cohort with T3 group stage up to the T4 after 6 months after neoadjuvant treatment trial. So the conclusion of our study is that CRCs, signet ring cell tumors, do not respond neoadjuvant therapy as tumor regression was not seen in any of the subjects. We suggest that such aggressive and resistant cancers as signet ring cells should undergo definitive surgical treatment without neoadjuvant therapy so that tumor progression and distant mets could be prevented. Lastly, we believe that treatment protocols should be individualized for this rare histologic subtype of rectal cancer. We have certain limitations. Firstly, it was a retrospective cohort study, so we couldn't do a clinical trial. And so, as it is a rare type of tumor and patient presentation in OPD is lesser than the rest of the adenocarcinomas, so it needs further prospective trials in order to make a guideline about surgery or neoadjuvant. Any questions, please? Yes, sir.
Can I have the mic? Yes. I'll be ready to answer any questions, but before I go to the question part, when my team was going to present this, they asked me that this is a controversial topic and what we are suggesting is totally against the parameters that are established कि आप सबका जो है इन rectal cancers का neoadjuvant treatment ज़रूर कराया करें. The results are in front of you. 21 patients, 38 थे जिसमें से fit for surgery 21 निकले. उन 21 में से 20 had no effect, none whatsoever. In fact, जो हमारे पास neoadjuvant के जो तरीक़ाकार हैं, if you go into the details, the patient comes back to us. Although the NCCN guidelines कहती हैं कि 5 to 12 weeks आप wait करें surgery के लिए, लेकिन जो हमारे surgical crowd है internationally and nationally, most of the crowd waits more than 8 weeks. And हम Professor AMJAD चीमा की टीम के साथ हमारा ख्याल ये था कि हमें 12 weeks तक उसका full फ़ायदा जो long course दिया उसका मिलना चाहिए मरीज़ को. तो at 12 weeks जब हमारे पास patient वापस आता है तो it's already too advanced even to do anything. And I tell you from a lot of experience now that it's a very, very difficult death to die of a locally advanced rectal cancer. It's such a miserable life. We do give them a stoma to avoid obstruction, but the life that they have is so painful that हमारे पास जाहिर सी बात है उसके अलावा heavy pain killers हम दे देते हैं, लेकिन मैं जो suggest नहीं कर रहा हूँ, मैं ये कह रहा हूँ कि कोई हमें ज़्यादा trials की ज़रूरत पड़ेगी at a national level or maybe at an international level as well, before we say to the crowd कि look, here the neoadjuvant is not working, upfront surgery, or जो बेहतर ऑप्शन मुझे लगता है कि शॉर्ट कोर्स दे दो और फारिग करो.
Right.
मैं यहाँ पे 2 बड़े-बड़े ऑन्कोलॉजिस्ट मेरे बराबर में बैठे हैं तो डॉक्टर नदीम अब्बासी, व्हाट डू यू थिंक?
अच्छा देखिए, सबसे पहले फर्स्ट ऑफ ऑल योर प्रोफेशनलिज्म एंड एथिक्स. तो आई थिंक इट इज़ ग्रेट टू ब्रिंग कंट्रोवर्शियल इशू. दैट इज़ वाई द कॉन्फ्रेंसेज आर देयर. ये कोई क्लास रूम तो नहीं है ना. दिस इज़ नॉट ए ट्यूटोरियल थिंग. आई थिंक एक्सेलेंट. थैंक यू वेरी मच फॉर ब्रिंगिंग इट फॉरवर्ड एंड आई कॉन्ग्रेचुलेट योर टीम एंड स्पेशली दिलीप एंड योर सेल्फ. नंबर वन. नंबर टू, एक मैं बड़ा क्लियर कर दूँ आपको, बीइंग स्टूडेंट ऑफ रेडिएशन ऑन्कोलॉजी, कई जगहों पे आप लोग बीइंग सर्जन ये समझ रहे हैं कि इस पेशेंट की रेडिएशन हो गई है. अनफॉर्चुनेटली नहीं हुई है उसकी. क्या आप में से कितने लोग वाउच करेंगे इसको कि जब आप ओपन करते हैं तो किसी में तो सिवियर फाइब्रोसिस मिलता है, किसी में लगता है कि ये बेचारा शायद वहाँ वैसे होके आ गया बाहर से. तो ये क्यों हो रहा है? दूसरी बात है ईद के गैप्स, बकरीद के गैप्स, आशूरा के गैप्स. तो जब हम वर्ड यूज़ करते हैं ना, इस पेशेंट की रेडिएशन हो गई है, तो कहीं ये मफरूज़ा ना हो, हुई नहीं है उसकी, और आप एक्सपेक्ट कर रहे हैं कि जी वो आप इंटरनेशनल स्टैंडर्ड का आपको रिजल्ट मिल जाए. आधा सिंध प्रोविंस हमारा जो है वो कोबाल्ट पे ट्रीट हो रहा है, जो कि इट्स क्राइम. इट शुड नॉट बी ट्रीटेड एक्चुअली. ना करें, बेहतर है ना ट्रीट करें, फिर आप ऑपरेट कर लिया करें पहले उसको. तो पहला पॉइंट नंबर वन. पॉइंट नंबर टू बड़ा इंपॉर्टेंट ये कि ये डेटा जो है इसका जो स्ट्रेंथ है वो 220 आपका डिनोमिनेटर है, वो बहुत स्ट्रॉन्ग है. वो डिनोमिनेटर हमें बता रहा है कि एक्चुअली वी आर प्रैक्टिसिंग विद ग्रेट फ्रीक्वेंसी, लेकिन हमारे पास कुछ इक्वेशन लैक कर रही है इधर. तो तीनों को अच्छा होना पड़ेगा, कोलोरेक्टल सर्जन को भी, रेडिएशन ऑन्कोलॉजी हाई क्वालिटी की, और नंबर 3 पे जो हमारे भाई बैठे हुए, आपने कहा ना बड़े ऑन्कोलॉजी, वो इनको कह रहे थे आप, नजीब, मुझे नहीं कह रहे थे. अब इनकी जो कीमो के मसाइल हैं वो भी तो देखने होंगे ना, फ्रीक्वेंसी, टाइमिंग, ये मैं इनको टारगेट नहीं कर रहा. मैं बता रहा हूँ आपको कि उसमें भी बहुत सारी चीज़ें हमें देखनी है, कॉकटेल्स के अंदर भी. तो तीनों इक्वेशन के बाद एमडीटी से मसला हल होना है. ये बड़ी बात है कि आप माशाल्लाह बीइंग ए सर्जन इसको ला के और पूरा ब्लेम अपने ऊपर ले रहे हैं, आप इस तरह ना लें. तो आई थिंक सिग्नेटिंग डिफिकल्ट है, हमारा भी, ये सारी दुनिया का है. तो कोई चीज़ इसमें ऐसी नहीं. और नल हाइपोथेसिस आपने देखा 0.2 हमारा 23 आ रही है पी वैल्यू. तो आई थिंक वी शुड कंटिन्यू ऑन दैट. लेकिन इस डाटा को ना एक दफ़ा न्यूट्रल पैनल को बैठ के देखना ज़रूरी है. आई विल बी वेरी हैप्पी एज ए स्टूडेंट कि मैं उसमें रेडिएशन ऑन्कोलॉजी का आपका देख लेता हूँ. आपको जो है ना, ये जो ईद की 9 दिन की छुट्टियाँ रेडिएशन के बीच में जो आ रही हैं पूरे पाकिस्तान में, और बकरीद की छुट्टियाँ, इसके बाद आप वो एक्सपेक्ट करें अगर रिजल्ट्स, तो वो सॉरी टू से दैट. और मैंने काफ़ी हमारे सर्जिकल कोलीग बैठे हुए हैं, प्रोफेसर हारिस मेरे क्लास फेलो भी हैं, काफ़ी दफ़ा बात होती है. वो मतलब जब वो आप खोल रहे हैं तो आपको इतना वेरिंग डिग्री क्यों मिल रही है फाइब्रोसिस की. अच्छा, अब आते हैं आपका आखिरी सवाल, जिसमें मैं सॉरी फॉर टेकिंग लॉन्ग. शॉर्ट और लॉन्ग कोर्स में देखें, पूरा यूरोप शॉर्ट कोर्स कर रहा है भाई. आप ज़रा इसको, मेरी बात को येस या नो करें, अगर नहीं करें तो आप बता दें मुझे. तो फिर अब आगे आप लोग बात करें अपनी. तो मेरा ख्याल है ये मल्टी डिसिप्लिनरी मसला हल होगा, सिर्फ सर्जन से नहीं होगा, सिर्फ रेडिएशन वाले से नहीं होगा, सिर्फ कीमो से नहीं होगा. तो हमारे रज़ा भाई की जो बात है वो हमें लोअर जीआई की ना एक सिटी लेवल पे बनानी पड़ेगी, एमडीटी ट्यूमर बोर्ड. वरना हम हर साल माशाल्लाह आप करते हैं और हमेशा डिबेट आगे ही जा रही है. इट्स ए गुड न्यूज़ एंड आई थैंक यू ऑन बिहाफ ऑफ द पेशेंट्स एक्चुअली. तो आई फिनिश हियर, सॉरी फॉर टेकिंग लॉन्ग. डॉक्टर नजीब को, अच्छा इनको मैंने कोई बुरा भला नहीं कहा, बड़े मेरे, मुझसे बड़े मैं इनकी बड़ी इज्जत करता हूँ. सफ़ेद दाढ़ी है इनकी भाई.
अच्छा, दाढ़ी के बालों पे मत जाइए, सर के बालों पे जाइए. एक्चुअली मैं बड़ा नहीं हूँ, इन दोनों से छोटा हूँ. ओके, अच्छा बात तो सही है. मीन्स वी डोंट हैव अ डेटा ऑन सिग्नेटिंग कार्सिनोमा एंड इट्स अ पुअर हिस्टोलॉजी विद अ पुअर प्रोग्नोसिस. चाहिए हमें क्या, हमें चाहिए उसके मॉलिकुलर सिग्निफिकेंस के भाई क्या होता है उसके अंदर. वी आर लैकिंग ऑन दैट. वी ट्रीट ऑल rectal cancer stage 2 and beyond, locally advanced localized cancer with total neoadjuvant therapy now, concurrent chemo radiation or short course radiation, chemotherapy and then surgery. Previously we used to give only chemotherapy, only radiation or concurrent chemo radiation followed by surgery and then chemo. The advantage of chemotherapy, giving chemotherapy before, is that we can see whether the patient is responding to chemo or not. So if we have that data after 3 cycles of chemotherapy, if we repeat the CT scan and see that the patient is progressing on chemotherapy, we don't have to give further chemo. In adjuvant setting, we have to give the full 6 months of chemo. So that's the advantage of giving chemotherapy before surgery. Number 1, we can see the response. Number 2, I agree that short course, अच्छी चीज़ है. We can try short course in a short tumors, not long tumors, I think. And then we can try surgery. But upfront surgery, I'll be a little bit reluctant. The reason is if you do upfront surgery, before chemo or radiation, then we will have more side effects because the bowel will come down. Dr. Nadeem Abbasi will correct me if I'm wrong, and then the patient can develop more gut side effects.
And less oxygen. And less oxygen, so more side effects of radiotherapy post-operatively. Because it's all diathermy or sab ho chuka hoga wahan. Sorry, आप continue करें.
So upfront surgery will be difficult, I believe. It's better to give chemo, not full chemo, 2 or 3 cycles of chemotherapy, see the response, the patient is responding, continue with chemo. If not responding, go for short course radiation followed by surgery. What do you think?
Can a surgeon speak now?
Yes, absolutely.
Professor Siraj MEMON, excellent observation and a very sensitive one. And this is what we have discussed in another conference, and the surgeons are observing that. And this brings us to the point raised by Jamil, that our patients have different tumor biology. And we need to, and I agree with you, I published this in 2015. My paper's limitation was of a smaller sample size, and this brings us to your suggestion. We need a multidisciplinary prospective trial in a trial setting to establish that what kind of patients we are dealing with. The observation by many surgeons in town, and I'm sure up country also, that our patients of rectal cancer usually are not responding the way, and this includes signet cells and non-signet cells, the way we read in Western literature. But this will still remain an observation unless we have a good, robust trial.
Okay. I would like to acknowledge 2 third-year medical graduates, AFEERA and AZZAM. Please stand up. They made a team with Dr. Dileep to compile this manuscript. So please have a big round of applause for them. They really did hard work along with Dr. Dileep. Thank you.